bunch before. We had a couple before. So you know I am actually the oldest faculty in our department. I've been doing EMS almost a half century, and I've seen all these changes. I started med school 13 years after CPR was invented in 1960, which seems a long time ago, but it was so novel in those days. In those days, people who dropped dead stayed dead. Today, I'm working on a new project with American Heart Association on looking at all the state laws in the entire nation on automated defibrillators. What a boring thing to do. But it turns out the way they're stored, you know, it's kind of cool to have an AED, but it's not cool when batteries are dead, or the pads have, you know, and so on. Well, it turns out state laws are all over the place. So we're trying to see if we can get a standard thing. Think from 1960 when Saffer described, Peter Saffer, in Ocean City, Maryland, at 12:30 in the afternoon on September the 16th, 1960, at the Maryland Medical Society, true story, described CPR that they'd been inventing at Johns Hopkins in the 1950s. Interesting story. You know, before that, people who dropped died. And then now, fast forward now, the fact we have automated defibrillators, we take it for granted, but it all has infrastructure associated with it. Paul Rosenberger is one of my best friends. He is a younger brother I wish I had. For that matter, you were in Alabama, so you could be my younger brother.
Yeah. Probably related.
Probably related. Paul is the program director for EMS education for our division. Come sit up here for a minute, Paul. Just come pull a chair up because I'll let you do a few words too. Paul is a medic with a doctorate in education. I wanted Paul to be here for a lot of reasons. Number one, he's a nice guy no matter what you may have heard about him. Number two is that he's the living proof that EMS as a career starts typically in younger people, but there is a career path. It may be the fire service is your career path, and I hope it is, but only you know that. But I do want you to know that Paul is an example of the fact that there is a broad career path. I had a meeting a few days ago with a gal who is a medic, who is on the education leadership. I'm from Georgia, for the state of Georgia, and she is a medic who now in her 30s is on a career path of leading education for EMS for the entire state. That's kind of cool. So I just want you to know that, number one, I wanted to encourage you. Number two, I'd like for Paul to say a few words about his philosophy, about thoughts about how Paul is a master in learning techniques. Learning techniques sounds a little weird, except that there are things about the way the brain is structured that, let's just say that you're a golfer, for example, and you say, okay, I'm going to teach myself to chip, and you do it, and you work on chipping all day long, and you get pretty good at it. And then you go work on putting, and then you go work on driving. That, okay, that means I'll get really good. It turns out that is not the best way to learn, that the brain doesn't do best that way. That it actually learns best by chipping, and then going and doing a putt, and then driving. And that term is called interleaving. And that is an example of the fact that there are techniques that if you use these, you actually understand it better, and you hold on to it. It's true. And Paul is a geek in that. He and I exchange ideas. Geek is a compliment among us geeks. So Paul, take a word or two.
Sure. So you actually asked a really good question a minute ago. So he asked me, he said, you know, we're almost done with this program. I talked to, who did I talk to? You coming in? I don't know anybody's name, sorry. Sean? Tillman, okay. He asked me, he said, you know, we're almost finished with this program. We're getting ready to go to registry. I think that's May the 5th. And what is it that I can do to prepare myself for registry? And I told him, I said, you know, I think the two things. One is I know where you're at. We had a paramedic program in the basement for 40 years. In 15, the school here shut that down, and that went over to El Centro as well as Brookhaven. And so we taught a lot of students, a lot of Dallas students. And where you guys are right now is, I know you're tired, you're exhausted, you've had enough of this stuff. And so I would tell you, stay in your books right now, every single day, even if it is just 30 minutes. I mean, you don't want to look at it, you've had enough of it. But right now, you still have that hurdle to jump on May the 5th. And so it's not time to put the books down now. So stay in there. You know, some of the stuff he's talking about there, There's another one talked about spaced practice. And what spaced practice is that instead of cramming, it's the opposite of cramming. We tend to cram the night before that test. It's better to spend 5 hours broken up as opposed to 5 hours before the test. And so what I'm telling you to do is do spaced practice. You know, just stay in there, keep that fresh in your mind, keep that in your memory every single day. And at some point, you're going to take that test and you're going to do just fine. The other thing, I know every one of you guys are going to pass because you're here. I don't know how many people you have in your class, but what's here, 3, 6, 7, 8 people? You guys are here, you care enough to be here, and that speaks volumes to me. I mean, I don't think you had to be here today if you didn't want to be here. So just the fact that you're here tells me you care, and asking questions like that, how do I do the best that I can, is telling me that you guys are probably the top of your class. You may not be that A person, and that's okay. I was when I went to paramedic school, I was just a B paramedic. The people that got the A's, they're not even in the business anymore, so, for whatever reason. So I'll take a B paramedic any day of the week over an A paramedic. So stay in the books. Stay in the books.
Absolutely.
Keep at it. And then the other thing is, you learn these concepts one way, and you put them in here that way. You learn the same concepts, you put them in here a little bit differently. And so if you guys share that knowledge, you'll construct a better concept together. And so you can learn from one another, the social aspects of learning. And you'll come out with a new, stronger, deeper concept together. And so I really encourage people to study together, just because there's things that you're strong in that he's not, or there's things that you put into your head differently that he has, and together you guys can actually build a really strong concept. So I mean, just hang in there. I mean, I'm just really gonna encourage you to hang in there and keep doing what you're doing. Because
Can they email you that question?
absolutely, I don't have my cards, but I can go get them.
Paul.rosenberger@utsw.edu, and I'm Ray.Fowler at UTSW.
And Rosenberger's ROSENBERGER, not BURGER.
AUTSW.
WE, yeah.
Send us a note. Like to hear from you.
So yeah, I mean, I don't think the fact that you guys are here, you're gonna have a problem at registry. But if you do, reach out, and you have to tell me where you're weak at though, because I don't know. And if I could give you one really big test, I could go find those weak areas and help you target those. But I haven't seen any of your examinations, so I don't know where that weakness is.
Yes.
You do. You've seen your test scores. So, but yeah, always here to help.
Absolutely. We appreciate it.
Greatly appreciate it.
Thanks, Paul.
Fresh items.
All right, guys, let's buckle down for a little bit. EMS is actually physician practice, believe it or not, what you would say. Wuss, you couldn't lift a stretcher if you tried, you're right. I don't have arms like that. Under state law, it actually is thought of as a physician practice, it actually is, but it's done by you guys. And so we know that. The closest thing we have in the hospital to it is kind of nursing anesthesia, where you have nurse anesthetists and not doctors. They do their thing, put people to sleep, all that sort of thing, and theoretically there's a doc that oversees it. So what do I do as an EMS medical director, which I have been now I've actually been a medical director for 41 years. My job is to kind of overlook the practice and see what happens. For example, I could run a report on electronic medical record about endotracheal intubation. What kind of report would I run? What do you absolutely have to use when you do endotracheal intubation every single time? For that matter, supraglottic airway loss. Right, for the reasons we talked about last time. It does two things, but it measures the movement of air in the airway. And if you put a tube in and you have zero movement, take the tube out. You say, well, what if they're not breathing? I get that, but you should be able to you should have air going in, and then there should be CO2 coming out unless they are stone cold dead. That's right. So what kind of report would I run? I would say, okay, fine, I want to list all for endotracheal tube equals yes, and capno equals no. Pull those charts. If I have a chart, what the room just I love when hush. People go, oh, shit, did I do that? Because it absolutely, you must use capnography. 20 years ago, we didn't have capnography. 20 years ago seems forever to you. It's a blink of an eyelash to me because I'm old. And so we now have a tool that can 100% of the time determine if an ET tube is in the esophagus where it never belongs. We had that discussion. So my job as a medical director is to look at things like that. My job also as a medical, the three great risks of what you guys and gals do for a living, I know there are no gals here, is unsafe driving. Please be careful. It has never been shown that hurrying to or from the scene of an accident has ever saved a life. One of our docs yesterday was in a crash, multiple broken ribs. She got out okay. She had to climb out sunroof. Didn't kill her, totaled the car, you know, and somebody was going too fast. Please don't drive fast and do stupid things because you will hurt somebody. Let me strongly encourage you to go to EMS1.com and put yourself on the mailing list. You'll get an email every day, and one of the things you'll see at the top of every single email is a terrible crash that's occurred somewhere in our nation. You say, well, why do I want to see that? To constantly remind you of the fact about being careful. Number two is advanced airways. An ET2, do not put an endotracheal tube in if you cannot see the cords. Number one, if you can't see them, and number two, if you don't see the tube pass through the cords. You don't see it, don't do it, 100% of the time. And I will stand behind you 100%. Why? Because we cannot tolerate putting an ET tube in the esophagus. You will kill somebody. And when I got here 20 years ago and started running audits on the Vital system, I found that there was a substantial number of ET tubes coming to hospital in the esophagus. We did this last time. There are one of two reasons about why an ET tube would be in an esophagus upon arrival to the hospital. We did this last time.
Hit a bump and moved.
It either came out or it never went in again. That's right. And so we don't have time to spend on that. Because we need to spend probably 45 minutes on this. If you need to pee and poop, go do it. But, and I guess we're recording this, right?
Yes, sir.
The third thing is non-transported patients. You've got to be careful. It is absolutely certain that there are going to be plenty of patients that you don't transport. I look at the electronic medical records of EMS agencies in the Vital system every single day by the dozens. I especially focus on I especially focus on what we call the no-loads, the non-transports. And it is most certainly true. You can't make everybody go if they're awake, alert, lucid, not drunk, and they're in command of their faculties. No, you can't make them go to the hospital. And I'm about to be, the reason I'm in my monkey suit today is I'm about to be at 4 to midnight over in Parkland. And God Almighty, I don't want you to bring me every single person with a handcuff because we're busy as shit over there. You know, we're already overwhelmed as it is, not to mention the whole COVID thing. So, but the place that medics get in trouble is when they non-transport somebody with abnormal vital signs. My residents all know Fowler's first law, which is always explain the tachycardia. You say, well, that seems stupid. The patient who is in trouble is increasing their sympathetic nervous system. Sympathetic nervous system speeds you up to run away, and your pupils dilate, and your skin breaks out in sweat, and your heart pounds, and the rate of the pulse goes up. And the parasympathetic nervous system does what you're doing right now. It sits you down to eat, stomach juices run, heart slows down, your bowels evacuate, hopefully not on the table, and your bladder empties and so forth. That's the parasympathetic nervous system. They do this. They actually live this way at all times inside your body. When the sympathetic nervous system is overpowering the body, manifested most commonly by tachycardia, something is wrong with that patient. For God's sake, don't no-load somebody whose pulse rate is above 100. You've got to be careful. You say, Doc, maybe they're just anxious. Maybe. But they could be septic. They could have a pulmonary embolism. They could be on meth. Well, is the meth my problem? I don't know, but it may be the problem. So what I want to do for the next probably half hour, 40 minutes or so, you think, God, I've got to sit here this long. Let me take a break now. Is we're going to talk a little bit about the patient who's having a rapid heart rate. And as we approach the patients Oh, Pappy said, may he rest. My dad flew B-17s in World War II. He was a bad dude. He flew 33 missions over Austria. I was driving here to come have lunch with you today, and a B-17 flew over. Now, that was kind of cool. That doesn't mean a lot to you, but I'm going, God, okay, that's an airplane from 70 years ago, flying over here in downtown Dallas. What Dave's saying is that people kind of glance, but they don't see. They don't have a regimented thing to look for. I've got a medic in one of our agencies that is going to have to come rotate with me because this particular medic, having just finished school, will say, well, everything looks okay to me. No, they're not. Their pulse ox is 80. You go, why didn't they know that? Well, everything looks just fine. She's had a stroke, but she's doing okay, but doesn't put them on cap note. The protocol is quite clear. Put them on cap note. Why does he not do that? I don't know. Part of it is, if you hurt somebody and you get sued, what you will be sued for is called negligence. That's the legal term. There are two types of negligence that you could be sued for. One is simple negligence, and the other is willful and wanton negligence. Simple can be loosely translated as, well, I didn't know. I just didn't know. But willful and wanton is, I didn't care. And I have heard it in an EMS system, in this system that will be nameless, that said, come on, son, let me tell you how to do a no load. Really? You just got quiet. You heard it before. You've got to be careful. Because like it or not, signed on as the fire department, you are in the business of human service. You are. I'm going to go be taking care of the IV heroin addicts and the alcoholics who are killing themselves coming to Parkland this afternoon. And it's so tempting to say, well, God damn it, if they're going to do this, that to hell with them. It's not my job. I am a humanitarian. I deal with humans. And it is not my place to judge. Your job is to serve those that call us. Now, a lot of it is BS stuff. It is true, but you have to be careful. What this talk is about how to be careful. Are they awake? Do they seem to be obviously in distress? Do you hear anything? I want you to listen very carefully. Ready? Listen very carefully. And listen to the sound of my breathing. Now listen to the sound of your own breathing. You hear anything? Listen to the sound of your heartbeat. Actually, my cabin in Georgia, where I'm going there tomorrow, is so quiet, I can hear my heartbeat. That's how quiet my cabin is back in the West. That's a quiet place. That's really quiet. The point is, the body is pretty silent. And if you hear stuff coming from somebody, there's something wrong. You hear noise. What does this sound? What does that sound? That's an upper airway sound where air is having trouble moving into the airway. We see that in croup, epiglottitis, or a foreign body in the airway, and that is called what? God, guys, you're about to take an exam. That's called stridor. Repeat after me. Stridor. I can't hear you.
Stridor.
You have to know that word. That's on the exam. Stridor is an upper airway obstruction. It can be caused by a piece of meat sitting in the trachea. It can be caused by a little kitty who's got fever and has been running, now drooling, tripoding like this, going, that's epiglottitis. My kid's about to have an airway obstruction. I'm right now chairing a committee for the state of Georgia. Georgia's my home, and I'm on the state council for Georgia, looking at the devices by which you, Tillman, you can punch a hole in the trachea. God forbid you have to do that. It's called cricothyrotomy, but it's definitely out there. It's permitted under Texas statute. You will be allowed to do it. You looking forward to punching a hole in someone, especially when they weigh in at about 480. We call that chronic caloric toxicity. Or chronic Twinkie toxicity. I'm sorry, that's politically correct. I got to do this long talk. What's the quality and the speed of their respiration? How fast is their pulse? What is Fowler's first law?
Explain tachycardia.
Say it together. Always
Explain tachycardia.
I'll never waste your time. I'm your medical rep. I'm one of your medical reps. I'll never waste your time. For God's sake, be careful. Put your hand on the pulse, and if you get this, be careful. There's something wrong with it. Well, they're just anxious. Fine. If they're just anxious, have them sit down, take a long deep breath, and you take a long deep breath, and presently the pulse will come down. Fine. They probably were just anxious. But if it stays fast, something's wrong. What does the skin look like? Is it pale? Is it wet? And then any other obvious things like bleeding. But the most common sign of illness is an elevated heart rate. What accelerates us most? It's epinephrine. It's the sympathetic nervous system. Specifically, in response to stress, epinephrine is released from the adrenal glands, which are back here on top of the kidneys. making the heart beat stronger and faster and raising blood pressure. Now, so let's say for a moment that I started bleeding internally from something. And let's say it was painless, so I'm not aware of it. And so right now I'm standing in front of you and I start bleeding internally. What is the first thing that I would notice and then you would see about me if I started bleeding internally? I don't mean just a little bit, just gush internally. I would
Level of consciousness.
Peripheral.
You feel weak.
I'd get weak. Yeah. That's right. And I would begin to fairly immediately start getting thirsty. I need a drink of water, and I would be lightheaded. This is true. You say, God Almighty, Doc, you mean for every damn patient is going to be weak, that they could be bleeding to death? Absolutely. Well, this is a harder field than I thought it was. I know. I have kids that I'll be working with this afternoon who they were stars in high school. They were incredible in college. They did wonderful in medical school, and we recruited them to be residents in our emergency room. And I will spend a lot of time teaching them this stuff, or say, look, please think about this, because you say every damn patient I'm going to see this afternoon who's weak could be bleeding to death. Yes, it's on the differential, which means it could. Does it mean it is? No. Could it be? Yes. Then you get pale. Then you get diaphoretic, which is sweaty. Then you get tachycardia. Notice the tachycardia is kind of down the road. You can already be bleeding to death, but just be pale. But then eventually the pulse rate speeds up. Then the brain is not getting enough oxygen, and you accelerate your respiratory rate. And then the kidneys, which sit here, you go, I am a paramedic. I don't think about piss. Well, you should. Because what's normal urinary output for an adult? Who knows? We covered this last time. 0.5 to 1 cc's per minute. How many minutes in an hour? That's easy. Here, check it on my smartphone. Check it on my smartphone. That's a joke. How many minutes in an hour? 60. All right. So if you're putting out normally 0.5 to 1 cc's per minute, say it.
30 to 60
cc's per hour. Why does I am a paramedic. I don't think about piss. You should. Because you're going to run to a nursing home. Aunt Minnie's got a Foley in. Aunt Minnie's temperature is 104, and she's altered with a pulse of 130. And she has a Foley in. The Foley is empty, it has a little mud at the bottom. You've all seen that. And you say, according to the Biotel protocol, you think she's in septic shock because she is tachycardic and altered. And so you deliver a 500 cc bolus of normal saline. And were she to be normally hydrated with normal kidney function for the next hour that you're with her, what should she be putting out at least if she's normal?
30 to 60.
Well, 30 to 60 cc's. But you just give her the bolus, and you give her the bolus, and she still puts out nothing. Where is she on this? This is progressive compensation. Compensation means the vascular system is trying to hold on to itself like this to keep the body from dying. But then finally it fails. And that's called decompensation. The decompensation, we take these words for granted. Decompensation means the body's about to die. Is that there is nothing in the vascular system that can hold on to the circulation and the body's about to die. How do you know that somebody's about to die? At what radial pulse, at what systolic pressure does the radial pulse appear? We did that before. It's about 80. 70 femoral, 60 carotid. So let's say you walk in the room, let me borrow your arm for a second. Let's walk in the room, you borrow your arm. I always sit there, hey, I'm Dr. Fowler, how are you feeling? And if he was pale, diaphoretic, and I couldn't feel a radial, I quickly do this and I can feel a carotid. It's very fast and weak. What's his blood pressure? 60 to 70, something in that range. You say, you mean I can do it that easy? Sure. It happened to me in the ER last time I worked. I had a lovely young woman who came in. Am I supposed to notice that someone's beautiful? I'm an old guy. What can I say? It's either that or watch reruns of Law and Order. This lovely young woman came in sick as a moose. I'm going to give you a clue about how somebody looks sick. They come in, pushing them in a wheelchair, and they look something like this. Ready? This is kind of subtle. I know you may not pick it up. She was gray and wet, sitting up in the wheelchair. Folks, if you have a weak radial pulse, get their ass flat, please, in a hurry. Because it takes more pressure to be able to get the head upright, to be able to use the brain. She looked like this. I said, God, Jesus. And so I went, hustling in the room with her. She had no radial pulse. She was gray and wet. I could feel a carotid. What was the blood pressure?
At least 60.
It's kind of handy. It is good. So I use it every day. If I use it, you should. She was sick. Turns out she had lupus of the bowel. You talk about rare, Parkinson's, rare stuff. She was having profound diarrhea and was actually having hypotension, shock, due to diarrhea. Interesting. You don't see that a lot. That is how people die of cholera, is that they diarrhea to death. It's true. But there's not a lot of diarrhea. Anyway, so weak pulses, then they get altered, then they have cardiac arrest, and they die. Weak, thirsty, lightheaded, pale, diaphoretic, tachycardia, tachypnea, diminished urinary output, progressive compensation, followed by decompensation. Decompensation is weak pulses. You come in the room, they're pale, they're wet, and you feel a weak or nearly absent radial pulse. That patient is what? Decompensated. That's about it. You'll be one of the only people in the field that know that. It's common knowledge, but now what Pappy said, common sense is not common, he said. So when they get weak pulses, they're decompensated, which means they're about to die. The vascular system has failed. We got to keep going. And for whatever it's worth, we don't do lactate levels in the field. There's been some effort. Lactate is produced, you work out like this and your muscles burn and you get lactate in your muscles. You've read about that. Lactate also shows up in the body in elevated levels when the body is ischemic, when it's not getting perfusion, when it's in shock. And we look at that. We may see lactates in the field passing. So a low blood pressure means either a loss of volume, low cardiac output, or increased vascular space, or a combination of these. For example, you can get shot and be bleeding to death and also have low cardiac output due to a tension pneumothorax. You say, well, that's complicated. I know. I had that patient the other day. So it does happen. It's a little uncommon. I just finished a study with one of my students on sepsis in the field. Sepsis is an overwhelming infection that's killing somebody, manifested by tachycardia, shock, fever, altered mental status, and so forth. People who are septic dilate their vascular space. We don't have a lot of time to spend on that. That would be a great another discussion. Should you want to get together? Down with it. But there actually are three different ways you can go into shock and die. Loss of actual volume in the blood system, which could be blood or fluid. Blood is like trauma. Blood is like alcoholics who drink themselves to death and rupture a blood vessel in their stomach, and then they bleed to death. That's internal bleeding. We call that GI hemorrhage. Or low cardiac output, such as a heart attack that's killing the heart muscle, putting them into shock. Or tension pneumothorax or cardiac tamponade. And then sepsis I mentioned, but also anaphylaxis. Anaphylaxis, getting stung on the butt by a bee, or people eat what? What is the most likely food?
Shellfish.
Yeah, isn't that funny? It's true. It is true. Some people react like hell to shellfish. And EMS1.com I mentioned to you this week had a case of that, was anaphylaxis in the field of this. And so then there's a heart kind of shock, which is a tachycardia with distended neck veins, and there's cyanotic. That is where the heart is failing. That is a tension pneumothorax. That is a cardiac tamponade. That is an MI with shock. I'll give you the slides if you want them when we're done. Lorenzo, if you'll write me, I'll circulate this slide set to everybody. Or they have loss of volume, which could be bleeding to death, or they could diarrhea to death. This girl almost died of diarrhea. She was in shock when I saw her. And they are tachycardic, but their neck veins are flat. Why are the neck veins distended in a cardiogenic shock? Because blood can't get back to the chest, so it backs up into the veins. In the setting of someone who is bleeding to death, there's no problem with blood getting into the chest, there's just not enough blood. And then there's vasodilatory. For example, like anaphylaxis, you get stung on the butt by a bee, your blood vessels dilate, and you have vasodilatory shock. Sepsis is another example. And the reason I said it was a variable pulse is that there is a thing called neurogenic shock. People who fall, hit their head, and have a bad bleed inside their head, at the very end of their life, they will go into vasodilatory, and they may in fact have a bradycardia. That's called neurogenic shock. I don't spend a lot of time on this. Now, this gentleman is a gift. You have to memorize this number, sir.
Sorry to interrupt. The flat neck vein, is it clearly visible, or do you have to feel?
Well, it depends on you. You've got a few more biscuits on you than me. Anybody? I'm gonna come to your house and say, it's ours, darling. I demand a paternity test. I go over the charts before I go into the ER. I sit at home. This is what an old man does. He sits home, looks at the charts, and evacuates his bladder, and watches that cute girl on CNN. It depends. There were patients in the ER that I was looking at the charts today that weighed in at about 340. They have a neck the size of a tree trunk, and the fat surrounds the veins. You may not be able to see it. You take Sweet Sue, who's just fit as she can be, and you can see her neck veins from across the room on a good day, because when she works out, they bulge a little bit. It depends. I mostly, because I'm used to doing it, I mostly can see neck veins. I could go around the room probably the sun. I'm sure I can see y'all. So I'm not sure about Paul's. His BMI is approaching 30, and so it depends on the person. That was a long answer to your question. Did I answer the question?
Yes.
Okay. Folks, this is a gift. You memorize this equation. Say, I will.
I will.
I'll never waste you. I'll never waste you. My residents know Fowler's Law, and I yell at them if they don't. I always explain the tachycardia. And this is what this slide, we're going to get into this heavy in the next few minutes, is the following. A lot of people will have a fast heart rate. Fast heart rate is usually the acceleration of the heart, like if you're going to work out. But there are a lot of reasons the heart can accelerate. For example, let's say that somebody has a pulmonary embolism. The heart can accelerate, blood clot going to the lung. Let's say that somebody is septic. They can accelerate their heart rate, right? Let's say that somebody is bleeding to death. They can accelerate their heart rate, right? The reason for this slide is as follows. You're going to come across patients from time to time that have very fast heart rates. It turns out that the maximum that you can, if I took a treadmill, something I used to work out on, and I get in like this, they put the leads on me like this, and then some guy stands behind me with a shotgun and goes, I'm gonna turn this thing on, and I'm gonna turn the monitor on and watch your heartbeat. And I'm gonna turn it faster and faster, which will accelerate your heart rate because you're working harder. And if you fall off, if you fall off or jump off, I will kill you. Well, it's kind of morbid, isn't it? You don't want to be killed. So, turn it on, I start going like this. And they turn it a little faster, I start like this. Monitor's going. You know how it will do, right? And he does it, and I'm going to start beginning now. It turns it like this, I'm going. All right, how fast? I'm almost 7. I'll be 69 in a few months. Let's use 70 for easy math. Given this formula, what is the fastest my body can accelerate my heart?
150.
Sure, 150. And so, like this. So if you saw it at 170, what statement can you make? It cannot be sinus tachycardia. You go, wait a minute. God in Exodus 4:18 did not mean that to be, I'm sorry if that offends, I didn't. Yeah, but I mean the fact that cannot be a law. Turns out it's true. You say, wait a minute. No, you could be able to accelerate your heart rate to 500. How about to 1,000? Turns out that's not so. There are physiological reasons for that. It has to do with how fast the sinus node will actually fire, which has to do with the width of the action potential. Don't worry about that. It's 0.4 seconds. Don't worry about it. So it just turns out that under normal cellular physiology, the sinus node, which is what controls the rate of the heart, won't go any faster than about 220 minus age. Now the natural question would be, what's age got to do with it? And it turns out that from the moment we start breathing when we're born until the time you get old like me and even older, Anthony Fauci is 80 years old, wonderful shape. Our president is 78, wonderful physical shape. They work out every day. I work out, I walk to the couch, I sit, I do this. And it turns out that the sinus node is fibrotic. It scars with the advancing years. So it becomes harder and harder to accelerate it to the passing years. So that to the 220 minus age actually has a pretty narrow bell curve in research. And so you have to know this, and we're going to go with several examples. So a newborn baby has an age of 0. 220 minus 0 is what? You could see a sinus tach on a newborn infant of 220. You say that can't be so. It's true. You take fatso. When I made this slide was 7 years ago. Let's make 70 for easy math. What is my maximum sinus tachycardia? About 150. So if you saw me at 180 on a monitor looking like shit, what statement can you make? It cannot be sinus tachycardia. So the flip side of that is it has to be what?
SVT.
You don't know the diagnosis. It's a nice try. You don't know if it's SVT or atrial fib or atrial flutter or multifocal atrial tachycardia and so forth. But what you can say, those are all arrhythmias. There is sinus rhythm, the acceleration, sinus tach, the acceleration of the heart rate. And there are arrhythmias, two different things. Arrhythmias can just pop in. Atrial fib is common in guys my age, for example. So. And then Minnie, who's 80, if you put her on a monitor, what is her maximum sinus tachycardia in septic shock, in GI hemorrhage, whatever? Massive pulmonary embolism, 140. So if you found her at 180, she's 80 years old, what statement can you make? It has to be an
Arrhythmia.
Yeah, brand new stuff. It's good stuff. And you say, well, that can't be true. It is. I have been practicing for over 40 years. It's true. And I share this with my residents and my students. You say, well, how come we hadn't heard this already? I don't know. I wasn't there. But it's true. And what I'm giving you is stuff that I know is very important because I'm one of your medical directors, gentlemen, and I want to see from you a wonderful clinical practice. Gentlemen, respectful. Last time, when we were talking about inferior MIs and the relationship between inferior MIs and the right coronary artery, you were still thinking about it a little bit. Something to work on. I'm going to loan you my smartphone to read. One thing I do, I read all the time. I've already read 2 hours today. I read on shift, and then I look up the stuff I don't know. Please forgive the use of the word I. I'm not speaking from a vanity standpoint. No, I'm a little proud of it, is the fact that this is what it takes for me to be safe as a doctor. How much do you need to read as a medic? Should you be reading about everything you see that you don't know? I think so. So, put it another way, gentlemen, I wasn't being rude, I hope.
No, you're good.
But it's something to think about, and I would love to have one-on-one on lunch one day, and we'll do some diagrams and so forth.
Yes, sir.
About the fact that the right coronary goes here, and that's where T3 and F are. And the circumflex goes up here where 1L and V6 are. And the LAD goes this way, where AVR, V1, V2, V3, V4. Conceptually, it's not that hard, but Paul and I we just working our way through a book called Make It Stick, which is learning theory. It's very interesting because some people are quite able to take things and kind of layer them on top, and others are quite literal. And they're both right. It's just that people are different. Something. Anyway, please understand the context. So our pulses can only go as fast as epinephrine can accelerate the sinus node, unless there's a conduction problem, meaning an arrhythmia. It's true. At the bed, you say, I can tell that at the bedside, sure. 220 minus 8. You say, this ain't Minnie, and she's 70. And I know that the maximum sinus is there, but you come in and just put your hand on her pulse, and it's going, you know already that that's too fast for this to be sinus, therefore it has to be an arrhythmia. The question is it a life-threatening arrhythmia or not? We'll come to that in just a second. So really, you've got sinus tach, and you've got everything else. You have sinus tach like this, where you've got a narrow complex, a P wave in front of every single QRS complex. You don't see more than one because the sinus node is always, let's see this thing work. Yeah, it works. The sinus node is always regular, so that's a sinus beat, and that's a sinus beat. So another beat would be right there, exactly in between, but we don't see it. Therefore, this is sinus tach. And we find where a beat falls on a large box, 300, 150, 175, 60, 50, 43, 37, 33, 30. What do we see? 300, 150. What's the rate, gentlemen?
Say it again.
Okay, somebody help me. This
You said
falls
3?
on this big box, 300, 150. What is that rate?
155, 160.
Yeah, or 160 now. So it's fast. But it looks like it's sinus. So you've either got sinus or SVT, or SVT is also known as PSVT, which is paroxysmal supraventricular tachycardia. You know why? Because it turns on like a light. Paroxysmal SVT, aka paroxysmal supraventricular tachycardia. You're rocking along like this, goes bam, turns on like a light, and turns off like a light. It's a paroxysm. Paroxysm is like when your eyelid goes like this, you know, and it's a paroxysm. Or atrial fill, or atrial flutter, or multifocal atrial tachycardia, or ventricular tachycardia. The problem is telling the difference. We did the history of EKGs before last time, all the way starting with Augustus Waller, ending with Goldberger and the invention of the augmented voltage leads. These are the leads of Einthoven. 1912, he really started it in 1893. The leads of Goldberger in 19, for which he won the Nobel Prize, by the way. And the leads of Goldberger in 42, and then the leads from 1938. These are of the American Heart Association. These are frontal plane leads. Leads 1, 2, 3, AV, F, R, L. That's these leads in this plane. They see current moving in this direction. These are the horizontal plane leads. They see current moving in this direction. Frontal plane, horizontal. So, just as a quick review, this is the anatomy of the heart. This is the thing, the SA node, which is a group of neurons that is accelerated by the sympathetic nervous system. It's also decelerated by the parasympathetic nervous system. They flow quickly to the AV node, which God in her wisdom gave us that to keep rates above about the above the rate of 210 or 220 from going all the way to the ventricles. So the AV node is another set of neurons that delays the impulse from going down to the bundle branches. And so the heart conducts like this. It goes from the SA node through the internodal branches down to the AV node, down to the bundle branches, which then leads to the depolarization of the ventricles. And so you can see then that the depolarization of the atria is the P wave, and the depolarization of the ventricles is the QRS complex. That's what those are. The PR interval, the beginning of the P wave to the beginning of the QRS, is the delay at the AV node, because these nerves are fast, and it makes those noises. And if there weren't a delay at the AV node, that's what happens. The heart fills, here's the atria, here's the ventricle. The heart fills like this. SA node fires, atria depolarizes, then there's a delay at the AV node, then the ventricle is depolarized. So this is what happens. You with me? If there weren't an AV node, this is what would happen. Get the idea? Because the atria and the ventricles would depolarize at the same time. Why do we care? There's a thing called Starling law, which says that right before the ventricle, as it fills, it's called diastole, right before it fills, that if you will distend it a little bit more, it'll really contract really hard. That's called Starling law. So why do we care? Because when the heart fills like this, the atria depolarizes, empties into the ventricle, distends it a little more, and then the ventricle contracts. It's called Starling law. And so that's the atrial kick, like that. And the reason it happens is because of the AV node. It's true. And we get into all kinds of stuff. For example, if people have an arrhythmia like WPW, which you've heard about, Wolff Parkinson White, which is due to a Kent bundle that goes around the AV node, that can cause the atria and the ventricles to be polarized right on top of each other. We can get into all that stuff. So let's see what we got here. So, I'm sorry. What this was supposed to show, I'm sorry, I haven't looked at this in a while. Here's a regular old sinus Brady, and you know I'm sorry, trying to make my point. So impulse comes this way to the ventricles. This is what? What is that really?
V-fib.
It is wide, it is fast, and the size of the beat, called amplitude, varies. Notice that it's kind of big here, small here, big, kind of a little bit here, big here, big here, big here, small here. That is a varying amplitude, wide and very fast. That is ventricular fibrillation. Why do we care? Because instead of the muscle coming down and contracting like this, instead what ends up happening, the pump loses its ability to pump, and that is ventricular fibrillation. So we went through this last time, that the order of interpretation of the rhythm strip, what was that abbreviation? Does anyone remember? Did somebody memorize the abbreviation from last time? Rate, rhythm, P, PR, rate, rhythm, P, intervals, ST, T, U, and assessment. How do you spell it? How do you pronounce it? Arpistula. It's true. You'll be the only guy on the street that knows that. But the point is, that is how you interpret a rhythm strip. Rate, rhythm, P. These are the intervals. You can turn that into an I, S, T, T, U, and assessment. And anyway, that's the phrase. And so that is slow, that is fast, and that is kind of medium. And then this one is quite fast. So we did this already. The rate, rhythm, P, PR, QRS, ST, T, U, and you summarize or assess, abbreviated arpistula. We did this slide last time. This compares rhythm strip interpretation to 12-lead interpretation. 12-lead, using the Dubin method. Dale Dubin, plastic surgeon from Florida, was the living proof that even surgeons can read EKGs. And he made a lot of money in his first 3 editions of his book. You may know the story on this. You can look it up on Wikipedia. And then he had a small problem with cocaine in teenage girls. Went to school, went to jail, lost his license, but then got out and did editions 4 or 5. He paid his price. He paid his debt to society. Lost his license, but came out and then did editions 4, 5, and 6. And the Dubin model is a pretty good read. It's easy. It's a program text. And it helps you about 12-lead interpretation, and it's what Ray used in 1978 to first really start learning EKGs 44 years ago. So that's the Dubin method: rate, rhythm, access, hypertrophy, and infarction. So the first thing you do is you really do a primary survey on the EKG. What is the point I'm trying to make here, folks? You look at the what, look at the rate. And now this gets to your point from a while ago. Sinus tach with a rate of 150 or over and SVT look a lot alike. The sinus tach should have P waves that you can see. And the maximum rate of sinus tachycardia is what?
220 minus 8.
I'll never waste your time. You must know. SVT does not, or PSVT, does not have discernible P waves in front of it. And the reason is it's not coming from the sinus node, not firing the atrium, which is what produces the P wave. And thus you may not see P wave. SVT, by the way, is not usually life-threatening. It usually doesn't put people in shock. They've often been in it for days, coughing, taking a dump, trying to do stuff to Valsalva, because they can usually get themselves out of it. That's pretty much normal. Plus, there's a thing about human nature, folks. People don't want to be sick, by and large. They really want to make it, in their mind, go away. Is that normal in human nature? You bet. And you're going to see it all your life. But finally, they just can't get rid of it. But SVT usually doesn't cause shock because it typically occurs in a heart muscle that's pretty strong. Except in the rare setting of a patient who's having a heart attack associated with the SVT, and that can put them in shock. Or the SVT in the setting of an MI can make the heart attack worse. And if that is the case, on a rare occasion, a guy, and let's say your ETA is 15 from Parkland, and it might be, right? And you're out there, and the guy, not only is he in SVT, he's 60 years old, and he's having an acute anterior wall MI in addition to his SVT, you have an indication of cardiac. Start an IV, get him some Versed, get the doc on the freaking phone, because he also, you hope, because you're shocking already a man with a heart attack, but that could be an indication. Now, even more importantly, you can't tell if a rhythm is sinus tach or SVT, assume it's sinus tach, unless the rate is faster than 220 miles. I'll never waste your time. It may be difficult or even impossible to see irregularity in really fast atrial fib. Atrial fib with a rate of like 190, it can be very hard to pick up irregularity in that rhythm. I carry with me here, that I have with me all the time in my white coat. I carry calipers. You've seen those. If you'll carry them, I will give you a pair. If you'll let me know, take up the thing, and I will send you a dozen pairs. I use calipers. Old man here, I'm the only guy in the ER with calipers, but I've used them for over 40 years, and I have now. I say it with some jest about the fact I don't know why you kids don't have to have calipers, whereas old blue here has to have his calipers. But I use them all. Always explain a tachycardia. Don't depend on the presence of a tachycardia to determine that an emergency is present. You got somebody who can't stand up and they're lightheaded and their pulse rate is 60, be careful. you got somebody who can't stand up and they're lightheaded and their pulse rate is 30, as you put them on the monitor, you may need to put them on what? Soon. Sure. All of the people that work with me in Garland and in Lancaster and in DeSoto, I read their EKGs every single day. They come to my laptop. And they get questions from me every week. When I see a Brady, I'll send them a note, did they put on pacing pads? Because that's one of the things I want to remind the medics to do. Sinus tach is a physiological response. We're going to look at some EKGs. Now, the maximum sinus tach is 220 minus age. So, here is a 30-year-old. 220 minus 30 is what? You guys,
90.
you have to go here. I'll just get out my calculator.
There you go.
90.
You know, it's funny, I learned, did you learn your multiplication when you were a kid? What's 9 times 9? 81. Yeah, it's funny, you don't have to think, it's an automatic response, like V50, it is. That's a certain kind of memory, we call it analytical memory. And it's very quick, it's already memorized. What I miss, you know, I'm an old guy, but there were people even older than me, I know it's hard to imagine. But the people in the generation before me learned to the 15s by 50. That would have been kind of helpful. What's 15 by 50? 225. But don't ask me what 15 times 13 is. I can't do it. But if you ask me what 12 times 12 is, I know it. 144. Sure, you know, because it's a visual. Hope y'all don't mind playing intellectual games here. So let's say 300, 150. What's the rate about, Rob? About 160, would you say, something like that? 160, 170, would you buy that?
Sure.
So you find one that, you remember those numbers again, right? Find one that falls on a big box. You remember the reason why? It's because of the speed of the paper. 25 millimeters per second, 5 big boxes per second. 5 big boxes per second is how many per minute? 5 times 60 is what? Whips out as
300.
300. Huh? 300, sure. Which means that if you have a beat fall on every big box, the rate would be what?
300.
300, sure. And every other box would be what? 150. And every third box would be what? 100. And every fourth Tillman would be.
A little bit down from that.
I like picking them.
A little bit down from
Not my smart enough. 75, 60, 50, 43, 37, 33, 30. Why do I memorize that? Because I use it. Do medics need that? I don't. You'll have to answer that for yourself. But I do know absolutely one thing. If you do not use it, you will not remember. So, room got silent all of a sudden. So, Paul and I have been at the podium many hundreds of hours in my career. It's kind of interesting when people start going, dude, you know, you can kind of feel that sense. It's true. So we know that the rate is around 160 to 170. The machine is pretty good about counting it. It says 149. I make that a little faster than that. But having said that, it's a 30-year-old. Maximum sinus tach for a 30-year-old is what? 190. Is 190. This is 150, we'll say. So your first response, especially with this being a narrow complex, is that this could be what? Sinus tach. Which means the person could be quite sick. Focus. Here's a gift. It is never normal for a patient, much less an adult, to be lying in the bed with a near maximum output sinus tachycardia. That patient is about to die. They have a massive pulmonary embolism obstructing blood flow through the heart. They are in septic shock. They are bleeding to death. In the elderly, it's commonly a medication reaction of some sort. They are about to die. You say, well, maybe it's cocaine. It could be. But drugs are a diagnosis of exclusion, which means it could be cocaine. It could be that they dosed out on albuterol, which is, causes tachycardia. But they're about to die, and you got to go. Now, focus. This will shock your shoulders. One of the DFR is a fine EMS system, but it's also important for all of us who are in medical systems to look at other places that kind of do cool stuff. MedStar has done some cool things. MedStar is a different system. It's a non-fire-based system. And they've done some interesting studies, and they've come up with a term called SADS, brand new term, you ready? Sudden Ambulance Death Syndrome. Now, what in God's name does that mean? Sudden Ambulance Death Syndrome. What does it mean? They are actually, listen up, there are actually patients so sick, so about to die, that you don't even want to move them. I mean, you say, well, I got him in the bed downstairs on the rig. No, you don't. Because there are some people that actually are so close to death now, if you move them, they will surely die. Stair chair downstairs on somebody who is in deep shock will kill them. So what Vera Vifalani, who's the medical director, along with my good friend Brian Miller, who's the associate medical director at MedStar, and their wonderful team, Matt Savosky, who's one of their leaders, they studied this. And what they found was that there were a number of patients who were having a cardiac arrest right after getting into the ambulance, sudden ambulance death syndrome. And what were they? They were patients that were so sick that if you moved them, they died. You say, well, Jesus, what am I supposed to do? Start an IV, put them on a monitor right where they are. If they're in septic shock, give them a pressor, give them a volume bolus, and get them better before you move them. If I do that in my fire department, they will fire me. Blame it on me. There are people that actually are too sick to move, and you have to be careful. Because you don't want sudden ambulance death syndrome. This is true, it's published. Happy to discuss it with you further. I'll turn you on to some good data. So there are some people that are so amazingly sick that you got to be careful when you move them. So what is this road? All right, well, I see. What's the first thing you look at?
Rate.
What's the next thing you look at?
Rhythm.
Okay, so what do we see? The rate is 350. It's about 150. The machine reads it at 156. The rhythm is perfectly clocked, regular. Okay, so it's I can't really say. The place that you look for P waves, here's the heart sitting in the chest this way and lies down. The right atrium is right here. V1 is sitting over the right atrium. You reckon V1 is pretty good at picking up P waves because it sits right over there? Yeah, it is. Whereas lead F is way down here, way away from the heart. And so F may not see P waves so well. So you look over here and say, well, the rate's 150. Do I see anything that looks like a P wave on this very jittery electrocardiogram? Yeah, I see this thing, but I don't see it on every beat. So I don't know. And so I suspect that this is an arrhythmia. So let's look at the QRS complex. It's not wide. 0.10 is considered incomplete bundle branch blocking. 0.12, 120 milliseconds, is considered complete bundle branch block. So this is not wide. So this is a narrow complex supraventricular tachycardia at a rate of 156 in a 55-year-old female. What is this rhythm? And I will give you a clue. It turned on like that. I just told you the answer. Good. Narrow complex. What's the old name for SVT? PSVT. Which stands for? Sure. And if we had it when it turned on, it would turn on just like that. This is what SVT looks like. One of the clues to SVT is that it is absolutely perfectly clock regular, because it has a circuit rhythm in the AV node. They're going to go up and down, up and down, up and down, up and down like this. So it's actually moving in a circle, and that's why it is perfectly regular.
Sir?
Sir?
Did you get SVT just off the rate by itself, or?
It may be generally stated that for a circuit rhythm to start in the AV node, it has to be a rate of about 150 or
Okay.
so. SVT, however, can go very rapid, 220, 240, turns out. It's always clock regular because it's a circuit rhythm like this. And so a clue was this, 150 or above. A clue was this, perfectly clock regular. A clue, you tend to see SVT more often than females. Tend to, not exclusive. And then I don't see P waves. So
Okay. Because
it took more than one fact, didn't it?
yes, the 220 minus the H
Yeah.
would still put her at sinus tach.
Right.
But I guess if you don't have P waves, then it's SVT. That's the last kind of key.
You mean a freaking medic had to actually sit and figure something out? I mean that respectfully. Yes. And the answer is yes. Do I do the same thing? Absolutely. I sit there and stare at stuff. There's some other clues. For example, there's a thing called respiratory. How's our time? I need to shut up very soon. How's our time? Yeah,
219.
Oh, 15, 20 more. Y'all,
yes, sir.
y'all cool?
Yeah.
I mean, I'll shut up whenever you want to. Lay back in your chair, but don't lay too, not this. But sit back in your chair, and I want you to put your finger on your radial pulse. Not so hard that you occlude. And I want you to breathe. Relax. I want you to breathe all the way out. Pay attention to the radial pulse. Now breathe in slowly. And what happens to the radial pulse?
Faster.
It goes down.
Oh, shit.
Well, now breathe back out again. I see it. Do it again. This is, but the term, and that people actually vary a little bit in terms of what happens with the term is called respiratory variability. Hey, listen to this. This is a one-liner. Wake up, Lawrence. The sign of a healthy heart is the presence of respiratory variability of the pulse. That's a sign of a healthy heart. It's true. This is published. Sign of an unhealthy heart. For example, even in the elderly who's having a funky chest pain. If they have sinus, but it's perfectly clocked regularly, it turns out that that is indicating of ischemic heart disease. It's true. These are just little facts. So the point is, when you put somebody on a monitor, and you'll do that, a dozen times a day, look for respiratory variability because you will see it all the time. You say, you mean if somebody loses respiratory variability, they may be prone to having a heart attack? Yes. Which is why I'm sitting at home watching Law and Order, smoking a pipe occasionally, legal stuff. And going, is it Barry? Is it Barry? Lorenzo.
Yes, sir. Last time you explained what that most people don't count AVR as a valuable lead, but
Yes.
you said I remember you were talking. I just didn't catch exactly what you said that it actually helped
You tell me.
diagnose.
All right, you tell me. Right ventricle, left ventricle. The heart sits in the chest this way and lies down. The right, there are two coronary arteries. The right goes that way, due south, in what's called the atrioventricular groove, toward 2, 3 and a half. The left coronary splits, and one branch is right here, going to the septum of the heart, where the bundle branches run, which is why leads V1 and V2 that sit right over the septum are looking at the area that, go figure, if you had massive ST elevation in V1 and V2, indicating that the LAD was occluded, does that mean that your bundle branches might rot due to a heart attack in the septum? And you go into complete AV block? You bet. That's why we use septal leads as a word, is because V1 and V2 could be a little more predictive that the patient's heart may stop because you infarct the bundle branches. All right, AVR is not over here. AVR is actually right here. You think of it over here, but it actually isn't. It's right here. Here's the right coronary. Here is the left coronary. The left coronary has a left main original piece, and AVR looks right at the left main. It looks right at it. V1 is here looking at it from an angle. AVR is looking right down at it. Now, why does that matter? Because if you see ST segment elevation in AVR, you may be having a left main infarct. Massive part of it. Because the left main branches to the LAD and to the circumflex. Circumflex goes out this way. You occlude the left main, you will rot the whole anterior heart muscle, not to mention the septum with the bundle branches. Does that make sense?
Yes.
So AVR is not a trash lead. It is not. There's some other areas where it's useful, but I don't want to pile stuff on you. An example of that is pulmonary embolism. Another example of that is in teenagers. Forget I just said either of those. So AVR is one of your anterior leads. So in summary, to remember this, these are the inferior leads, right coronary artery. These are your lateral leads, 1, L, and V6. And these are your anterior leads, AVR, V1, V2, V3, and V4. So you get an L, and sort of a straight line, I, and a T like this. But don't memorize it that way. Learn what the cardiac is. And over time, it'll come to you. It took me a long time. Dubin's book helped me. Anybody who wants a copy of Dubin, I'll buy it for you. Standing on. You just have to tell Lorenzo, we'll work it out. So we did all that. So this could be sinus tach, could be, but it turns out it isn't. This was SVT that we talked. We'll do one or two more. If you forget everything else, remember that patients having near maximum sinus tach laying into bed are about to die. There is something terribly wrong. But what if they just did meth and they are 19 and they have a rate of 195 that is sinus? Are they about to die? Probably not. I might give them a little verse. It's probably going to go away. What if it's old Aunt Minnie, who was fine and is now lying in the bed, very short of breath, has a bloody cough, has anterior chest pain, and she's 80. 220 minus 80 is what?
140.
140, right? And she has a sinus attack at a rate of 138. She's 80. She is short of breath. She's clutching her chest. She's coughing up a little blood. And by the way, she had a sore calf a few days ago. I'm giving this to you.
Pulmonary emboli.
Sure. And the thing about pulmonary emboli, if they give you a near maximum sinus attack, they're about to have a cardiac arrest. True or false? Are pulmonary emboli? Thank you. And you're correct. Just the answer to the question I haven't even given you. That was kind of a guess in that case. No. Are pulmonary emboli, massive pulmonary emboli, a significant cause of cardiac arrest? Sure. Absolutely. We see. I know you don't know yet, but absolutely. And so the point is about people in cardiac arrest, it ain't just the rhythm, i.e. VF, pulses VT, but it's what? It might have been a guy who's a middle-aged smoker who's now jogging and trying to get his weight off because the doctor told him to lose some weight, and he arrests suddenly. It might be. But it might be old Aunt Minnie lying in the bed with a phobia, and she's had a swollen calf and a bunch of other issues, and she arrests. This guy had an ischemic heart thing, and he arrests while he was jogging. Old Aunt Minnie with 100 medical problems. Is it a greater, if you can be right with this guy and do CPR and get an AED and buzz this guy, chances are he will recover. Whatever made Aunt Minnie so sick to go into cardiac arrest, it may be hard to get her out. Septic shock, pulmonary embolism. Like bleeding to death, like sepsis, like a tension pneumothorax, cardiac tamponade, like a ruptured aorta, like a ruptured ectopic pregnancy, like a massive pulmonary embolism. You say, how do I remember all that? Good luck. William Osler, great master surgeon from, Halsted was the surgeon. Well, Osler was a great internist from Canada who went to Johns Hopkins, said, diseases of the great vessels make humble men of proud physicians, because you don't think about it. We had a case at CQI this past Thursday of a dissecting aortic aneurysm and a guy who died in front of us. And nobody thought about aneurysm. It probably doesn't matter because we probably couldn't have saved him anyway. So it's hard to remember something that's mobilizing a massive physiological response, and your job is to determine if it could be sinus attack, and if so, to take action. So let's do 2 or 3 and then we'll stop. All right. What's the first thing you look at?
Rate.
What's the next thing?
Rhythm.
All right. So, what about the rate? Somebody help me. Let's find one that follows the big box. What would this be?
300.
What would this be?
150.
I love this.
100.
75. 60.
55.
50, 40, the old man, he's got white hair. He pees on himself sometimes. He can remember this. You guys are young stud muffins. What is the deal? Right. Do medicine need to know that? I don't know. You'll have to answer it for yourself. I do. So let's see. Somebody help me. Don't look up here. This is the last place I look. I am a medical record by trade. I see what medics do. I know what their behavior is. And medics, I'm a passionate reader of cardiograms, as Paul knows. I write a lot about it, I do. And I assumed, we only got 12 of these out in the rigs about 20 years ago. And I've been here the entire time. I assumed that medics, by and large, approached electrocardiography with the same passion that I do. It's not that I'm right or wrong, but I just assumed that, wow, I got this tool. I'm going to learn every freaking thing I can. Doesn't happen. Most medics, sadly, read this. Well, it turns out that this is pretty good. And that paragraph has gotten better. The term is called an interpretive algorithm. It's gotten better with the passing of time. It's especially good about rate, and it's pretty good about ischemia. It's good about left ventricular hypertrophy, by and large. So it's pretty good. But if you don't read cardiogram yourself, you will forget how to do it. What are the inferior rates? Somebody else.
2, 3, yeah.
What are the lateral rates? I'm pointing at you. What are the lateral rates?
1 AVL, 5, 6.
It's where the leads are positive. 1 L and 6, 2 3 and F, ADR, V1, V2, V3, V4. That's how they're grouped. All you have to remember is what leaves the hospital. 1L and 6, 2, 3, and L. ADR, V1, V2. That's all there is. For the 3 R's. Begin to make sense. Yeah, you have to work on it over and over. This is called adaptive learning. It's true. So what do we see? Well, all right, 220 minus that is what?
160.
160. So we have, let's find ones on a big box. Somebody help me.
There you go.
300, 150.
Say 225.
Yeah, 210.
The machine is really good about reading rate. I read it myself first, and then I look at the machine's number. So my question to you is what? You have that. What you have that. What statement can you make?
Probably not.
Could you be more
Arrhythmia.
firm?
It is not.
Very rare. You could probably say that with some degree of confidence, because there is a very narrow bell curve. It might vary. 220 minus 60 is 160, 165 to 155. There is a bell curve, but it's not 200. It's pretty narrow. That's published. I looked that up. So the first thing we know, if this can't be sinus tag, it what?
It's arrhythmia.
I can't hear you.
Arrhythmia.
It has to be an arrhythmia. All right. Well, then it's narrow complex. You then start with the fact, what are the narrow complex arrhythmias?
Atrial.
Every time I point at you, you go. Sure. What do old guys like me? Atrial fib, atrial flutter. And those are by far 90% of the narrow complex arrhythmias associated with anybody. SVT or PSVT. Atrial fib, atrial flutter. There are a couple of other more rare ones, multifocal atrial tachycardia, and some of the other derivatives. But the point is, they are an arrhythmia. You have already picked up by looking at this. This has to be an arrhythmia. Good. It is perfectly clock regular and narrow complex. So this is probably what?
SVT.
Yeah, it's probably SVT or PSVT. And if we had, he happened to be on a monitor and he suddenly, what was that word I told you about? It's a what?
PSVT.
It's a paroxysm. It turns on like a light. It turns off like a light. It's true. And so it probably is PSVT or SVT. There should be an R wave here, a bigger R wave here, a bigger R wave here, and a bigger R wave here as the V leads move around looking at the left ventricle. We don't see any R waves. The chances are this 60-year-old guy has probably had an old anterior heart attack. So this is SVT, 60 years old, 206, 200, 160. This has to be an arrhythmia. We also look at regularity. The sinus node, listen. Now I'm going to take a deep breath. What do we call that? What kind of variability? Respiratory variation is the word. I swear to God, if you'll pay attention, you'll see it on most of the patients. And what did I tell you about respiratory variability?
It's a healthy heart.
Has it, and the absence. Yeah, the absence of respiratory variability suggests ischemic heart disease. This is true. It's not widely known, but it is true. I'm going to go be in the ER in just a little bit. I do need to stop in about 5 or 6 minutes to go to the ER. And I'm going to be in there chain drinking coffee, and around all the chaos going on. And down the hall, I'm going to be hearing this. I'm also going to be hearing this, which often means cardiac arrest, but mostly in my world is that the guy has taken the pulse ox lead off or something. And what will happen with that thing going on? It'll go on for how long? Probably 15 minutes, probably 18, maybe 20 minutes. Why? What do we call that in the EO and in the rig? It's called alarm fatigue, and it's unfortunate. We should be going straight. I'm not criticizing Parkland. Parkland is a great hospital. I love it. I'm around wonderful people. I love our patients, even though some are hard to love. Meth heads and heroin addicts who are killing themselves. We patch them up, send them back out, and they come back again with an IV drug thing, with a fever and a heart murmur. But we have a lot of wonderful patients, But we get this alarm fatigue where we just start ignoring it. So you're going to hear this in the back of the rig. I'm gonna inhale. Normal or abnormal? Normal. That's actually listening to sinus rhythm, all right? So let's say you get this. You guys having chest pain, you get this. Okay? Is that regular or irregular?
Irregular.
This is regular. You say, this is the stupidest thing I've ever heard. You listen to monitors all the time. All the time. You will be listening to a dozen monitors a day. That old man here listens to monitors all day long, for years, for generations. I listen to them all the time. And you can just hear it. So, the guy's having chest pain, he goes into this. Is it irregular?
Mm-hmm.
Is it irregular? Is it regularly irregular
Regularly
or irregularly irregular? Say it.
Irregular.
Somebody say it.
Regularly.
What did you say? What did you say? Sure. It's irregular, but it's predictable, isn't it? That's what bigeminy sounds like. Bigeminy comes in two flavors, atrial and ventricular. The thing we worry about in the setting of chest pain is ventricular bigeminy. I had a case of EMS with that yesterday. We see it pretty regularly. Or irregular irregularity. You get, okay. Is that irregular? That's the stumbling drunk, if you will. That's what atrial fib sounds like. And you will hear it on the monitors all the time if you just listen. It's true. So, regular irregularity, bigeminy, trigeminy. Trigeminy is just one every third, PVC every third beat. Vinkerbach was actually the guy's name. He was a Dutch physiologist. We call it Winkerbach, but Vinkerbach is another one. And it's the guy with a limp, like I said. And so you have an underlying sinus rhythm with PVCs, and this is an example of bigeminy. Beat, 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 beat. It is irregular, but it is regularly irregular. You can also have one every third beat, or one every fourth beat. We call one every third beat trigeminy. We call one every fourth beat quadrigeminy. It doesn't matter. It doesn't apply severely. The thing I would worry about would be if you had somebody rocking along, he's having chest pain, and then he's got a millimeter of ST elevation in lead 2. I don't see anymore. He does have a prolonged PR interval, which suggests an acute inferior wall MI, and he's having bigeminy. That would worry me, because he is at a greater risk of doing what? Why do we care about bigeminy? Why do we care that the ventricles, normally the heart should be firing from here, and that the ventricle, where a piece of dead and dying muscle is sitting down here, starts firing spontaneously? Why do we care? Because the next thing that you might see, let me give you your ACLS test. Ready? You're rocking along. You might do this. Yeah, what's the monitor do? Yeah. What was that line I just gave you so you can pass your ACLS test? Or he's rocking along like this, and suddenly he does like this and lies down, and the monitor's going. What is that? VTAC. It's wide, it's fast, and the size of it is the same. The amplitude is what we call it. It's VTAC. I won't do VFib because it gives me bursitis. I don't want to spend time on Winkerbach. This is it. It's progressive prolongation of the PR interval until the beat drops. And you can actually, I turned off the thing. But that gets us more into advanced cardiac breathing. You can do it. I do it. But let's don't go there today. The clue is progressive prolongation of the PR interval until the beat drops. Notice that the atrial rate is always what?
The same.
It's always the same. Always the same. And it just happens that you have a progressive block at the AV node until finally the beat drops. If I told you that the right coronary artery in 90% of cases supplies blood supply to the AV node, then what would you expect to see on the EKG in this guy having a Winkerbach? ST elevation where? For the right coronary? Right coronary? 2, 3.5?
AVF.
2, 3.5, right? Right. It's not hard. It's a lot of information. And then there's irregular rate. There's atrial fib, there's variable rate atrial flutter, multifocal atrial tachycardia, other ectopy, that's the stumbling drunk, and irregular. And actually, I think that's where I'm gonna stop, because we get into some other things. Let me go to the very end and see if there was, I think I might have had. Yeah, I'm gonna go through these last. Here it is. So this is something I wrote a few years ago. To actually how to interpret tachycardia. This is a little flow sheet. So you start with the patient and take their pulse, and you find that it's fast. The rate's over 100. Then, what is the patient's maximum expected sinus tach? 220 miles per
Say,
And so, could it be sinus tach? If yes, then try to rule out and treat the causes, like bleeding, shock of any cause, anaphylaxis. Anaphylaxis, listen to me. People getting stung on the butt by the bee or eating a food like what?
shellfish.
Interesting that it is often unrecognized. And epinephrine is holy water to anaphylaxis. You stand in between people and death with epinephrine that you got drawn up. It's true. Just like for the defibrillator for ventricular fibrillation. It's true. Is it narrow, perfectly regular, and 150 or above, then it's probably SVT or PSVT, unless it could be sinus tach. Here's sinus tach. Here is, and this is actually, see what this is here? That's sinus. And then you get, bam, bam, this is called the warm-up of SVT. This is the beginning of paralysis. It's true. This initiates that circuit in the AV node, and then bam, 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 bam. See the difference between here and over here. Perfectly clocked regular narrow complex, and then a rate of about 180. And that's the warm-up phenomenon that I mentioned. Is it regular? No. If it's irregular, regular, narrow complex, it's probably atrial fib, by far the most common irregular rhythm that's narrow complex is atrial fib, and you will see atrial fib all the time. It has a very high rate. Is it wide? We'll stop at this end of this here. Is it wide and perfectly regular? It is probably VTAC. About 80% of the time it's VTAC. And if they go into shock, they lose which means they lose their radial pulse. Blood pressure is under what?
Radio
Under
80. 80.
So if they suddenly lose their radial pulse,
Right at 60.
and they got this, you have an indication to buzz them. And synchronized cardioversion is preferred. As opposed to this, it's kind of wide complex, but is it regular?
Nope.
No.
So what do you think that is?
You should.
This is probably atrial fib with maybe a bundle.
No.
And then finally, is it narrow or wide, regular, but with a sawtooth baseline? It could be atrial flutter, and that's a lousy picture of atrial flutter. I need to get a new one for that. Atrial flutter is typically narrow complex, and it's perfectly regular. All right, we'll stop. Questions or comments? This will be the last time we'll get together, though, Lorenzo, I'm happy to put together another one down the road. Maybe we can get together with, something a little stronger than coffee. See, after y'all get through the boards, that turns into a bar at 4 o'clock. So it's very sad. Melvin, the bartender, is a Honduran fellow. He's my buddy. And we sit around and tell stories about it. You'll be sitting there. I love the interview. You'll be sitting there having your drink, minding your own business, and a Nobel laureate will come in and sit down and go, "Hi, Mike, how are you?" "Hi, Ray, how are you?" He spoke. Make yourselves proud first. You're in a service business. Your job is to go to work, take care of people. I swear to God, that's true. I'm about to leave here and go take care of heroin addicts and meth addicts and so forth. And I swore that medicine is the art of compassion. You are a medicine provider. You can continue to move on in your career. Paul is emblematic of it. I bailed him out of jail. I weaned him from mother's milk to vodka. All lies. But Paul and I have a marvelous partnership, thinking about ways to help people think about stuff. Please look up everything you don't know. Try to remember this one last thing from this old blue hair who's been around a long, long time and is one of your medical directors. The day that you stop looking up stuff that you don't know is the day when you begin to be honest and question about why you're doing it.
Because I have to read all the time to take care of the people I've been taking care of for generations. If I have to do that, I know. So think about it, with the passing. You've got our email addresses, we'd love to hear from you. You wanna put together a post-exam, party to either celebrate or cry in our beer. But there are two reasons to drink after an exam, right? Either to celebrate or, questions, comments? Hearing none, I move we adjourn. Thank you for coming, there's some more food back there.
Thank you.
Thank you,
Appreciate
sir.
you guys.
Sir.
Thank you.
Hey, gentlemen.
Absolutely.
Thanks, Lorenzo.
I have the faith in y'all.
All right.
That you're here.